Good afternoon. I'd like to thank the opportunity of presenting our study, how reliable is laparoscopic colorectal surgery compared to open surgery for octogenarians. We have nothing to disclose. The increasing age of the population in the last years, especially in the US, where in 2010, the estimated population would be 40 million people, as compared to more than double for 2050. This would represent a percentage of 20.7% in 2050, as it was only 12.4% in 2000. Despite this, laparoscopic surgery in elderly is still not widely accepted because of a longer operative time and some complications, especially pulmonary and cardiovascular. For this reason, the published data is limited. That's why we decided to compare the surgical and early postoperative outcomes of laparoscopic colorectal resections as compared to open surgery for octogenarians. We retrospectively analyzed our data, prospectively maintained the database of patients, consecutive octogenarians who underwent laparoscopic or open resections from January 2001 to July 2008. We included patients with elective surgeries, abdominal colorectal resections, open or laparoscopic, excluding those who were urgent or emergent, surgeries without resection, and perineal procedures. So we ended up with two groups. Group 1 included open colorectal resections, and Group 2 included laparoscopic colorectal resections. We evaluated preoperatively age, gender, and BMI, the ASA classification, comorbid stays and diagnosis, as well as indication for surgery and previous abdominal surgeries. Intraoperatively, we analyzed the type of procedure, operative time, estimated blood loss, intraoperative packed blood red cells transfusion, and intraoperative complications. And within 30 days after surgery, we analyzed the ICU stay as well as recovery after surgery, seeing the length of hospital stay and time to first bowel movement and regular diet, the exacerbation of pre-existing radical conditions, as well as surgical complications and mortality rates. Regarding surgical complications, we divided them in minor and major complications as they needed any invasive procedures, such as reoperation or radiological drainage. For statistical analysis, we utilized the Fisher and Mann-Whitney tests as necessary, with a p-value less than 0.005 for statistical significance. So we had 199 octogenarian patients from whom 116 were included in open group and 83 in the laparoscopic group. Analyzing the preoperative data, we see that the age was similar for the groups as well as the other data, gender, BMI, and ASA. The comorbid conditions were higher for both groups as expected, and the previous surgeries were also similar. The diagnoses that indicated surgery were mostly cancer or large polyps for both groups, 86.2% in the open and 89.1% in the laparoscopic group, followed by diverticular diseases and other indications. Analyzing the procedures performed, most of the procedures were right or extended right colectomy in both groups. However, the right or extended right colectomies were more performed in the laparoscopic group as compared to the open group. And also, the abdominal perineal resection were mostly performed in the open group as compared to the laparoscopic. Maybe for this reason, the need of a stoma in the open group and the absence of anastomosis were higher for these two groups, for the open group compared to the laparoscopic group. Regarding intraoperative data, we see that the operative time were similar for both groups. However, the estimated blood loss and the transfusions after or intraoperative transfusion were higher for the open group as compared to the laparoscopic group, and the length of incision was, as expected, larger. Regarding minor surgical complications, we see that both groups had a similar incidence of complications, and major complications were also similar for the groups. We had 5.2% in the open group and 4.8% in the laparoscopic group. So the incidence of reoperation were also similar for the two groups analyzed. Regarding medical complications, here come the difference between the two groups, where the overall complications were higher for the open group, 38.8%, as compared to a 25.3% in the laparoscopic group, mainly due to cardiovascular and pulmonary infection, acute renal failure, and catheter sepsis. Analyzing the overall morbidity, we see that there was a 49.1% morbidity in the laparotomy group and 30.1% in the laparoscopy group, which made a significant difference, although the mortality was similar for the groups. So regarding the recovery after the surgery, there was a significant longer stay for the open group, 8 days medium, and compared to the laparoscopic group that was 6 days. Although the other parameters of recovery were similar. The conversion for our study was 25.3%, and we decided to divide the procedures in converted and non-converted procedures. And we see that when we divided these procedures, obviously the converted procedures had worse outcomes as compared to the non-converted procedures. The reasons for conversions were mainly adhesions due to private surgeries, followed by bulky tumors and unclear anatomy, and then other reasons. As there was a difference between converted and non-converted reasons in the cases, we decided to compare open cases with pure laparoscopic cases. And we see that the differences were more pronounced. The blood loss remained more higher in the open group, and other parameters favored the laparoscopic, such as the time to oral intake, medical, surgical, and overall complications. So in this table, we see that most case series that compare laparoscopy in older patients, not all of them analyzes octogenarians. Although seeing all these cases, we see that operative time was for most series higher in the laparoscopy, different from our study. The estimated blood loss for the studies which analyzed them was higher for the open cases as compared to laparoscopy. The time of hospital stay was also higher in the open procedures, and the conversion in our series was a little higher as compared to the other case series in the literature. The morbidity rates were also in some studies higher, and in other studies comparable with the laparoscopic and open procedures. And the mortality was low and similar for the literature cases as in our study. So we can conclude with this that laparoscopic colorectal resection as in octogenarians as compared to open procedures have a lower estimated blood loss and a less intraoperative transfusion, shorter hospital stay, and lower morbidity. These results are even more pronounced in successfully completed laparoscopic cases, and the laparoscopic colorectal resection is effective and safe for octogenarians. Thank you for your attention.
Thank you very much. That was, again, a nice contribution of doing operations in an older population.